Welcome to The Explainer. Today, we're unraveling a terrifying medical scenario, the iatrogenic fistula. We're going to dive right into how to safely map out some incredibly delicate pelvic anatomy. Because as you'll see, we're dealing with a disease process where a single, tiny misplaced movement, well, it can literally change a patient's life forever. Let's get right into it.
So let's kick off this clinical puzzle with a real case. Picture a 35-year-old guy who comes in with severe perianal pain and a fever. He has this large, straightforward abscess drained right at the 6 o'clock position. Initially, his pain totally resolves. But 3 months later, he's back. He's got this relentless, purulent drainage coming from a tiny opening in the skin. And here is where it goes wrong. A frustrated surgeon decides to force a probe inside, pushing hard until, pop, it goes straight into the rectum. Okay, so we really have to ask ourselves, why did this routine, albeit forceful, probing instantly create an iatrogenic disaster? I mean, we're talking about a high transsphincteric fistula that could absolutely doom this patient to lifelong incontinence. The ultimate mandate in fistula surgery is balancing the cure of the tract with the absolute preservation of fecal continence. Misunderstanding the anatomy here, it's a total zero-sum game.
Which brings us to Section 1, the hidden underground tunnels. Since perianal abscesses and fistulas are honestly just two phases of the exact same disease process, we need to really visualize the anatomy. Imagine a double-walled house, right? Your inner wall is the internal anal sphincter, and that heavy outer brick wall, that's the external anal sphincter. Now, imagine a leaky inner pipe fills the space between those two walls with water. If that water bursts outward through the outer brick wall, boom, you have an abscess. If that drainage path stays open permanently, it turns into an underground tunnel, a fistula. And if you decide to just smash down the outer brick wall to fix that inner pipe, the entire house collapses. Clinically speaking, that collapse means total fecal incontinence.
So, to figure out why that pipe leaks in the first place, we rely on the cryptoglandular theory. This framework basically explains that 90% of these abscesses are really just the acute tip of a much larger iceberg. It all originates from about 6 to 10 tiny anal crypt glands sitting right at the dentate line. When those glands get blocked up by debris or stool, a hidden intersphincteric abscess forms right at the root of the disease.
Once all that hidden pus pools up in the intersphincteric space, it's got to go somewhere, right? And it strictly follows the path of least resistance. It might track downward to the skin at the perianal verge. Or it could burst outward through the external muscle right into the ischioanal fossa. Or, and this is the terrifying one, it can actually climb upward, deep into the pelvis, way above the levator ani muscle.
Moving on to Section 2, Mapping with Goodsall's Law.
Since we obviously can't see these intricate underground tunnels with the naked eye, we absolutely need a reliable map to navigate this minefield without causing a catastrophic collapse of the patient's sphincter muscles. And it's actually super fascinating how we can predict the internal danger based purely on what we see on the outside. This is where Goodsall's law comes in. If we draw a transverse line right across the anal verge, we can accurately predict that anterior openings will run in straight radial lines to their origin. Meanwhile, posterior openings? They take a long, curved path to route all the way back to the posterior midline at the 6 o'clock position.
But hang on, before you blindly trust this map in the OR, you really have to ask yourself, what is the key exception to this rule? Because missing this one specific exception is exactly what causes surgeons to make catastrophic errors in judgment.
The trap lies right here in the 3-centimeter exception. If an anterior opening is more than 3 centimeters away from the anal verge, it actually does not run straight. It curves all the way back around to the posterior midline. What does that mean for us? Well, if you try to probe it straight like a standard anterior fistula, you're going to forcefully perforate perfectly healthy tissue and create a completely false high tract.
Let's jump to Section 3, the Parks Classification Framework.
Now that we've mapped out how these tunnels travel horizontally, let's look at the vertical distribution of the disease through the Parks classification system. This stages fistulas based on their relationship to the external anal sphincter. The good news? About 70% of fistulas, thankfully, stay entirely within the intersphincteric plane as type I, so they never cross that external muscle. But nearly a third cross over into much more dangerous anatomical territory.
And those complex outliers are where the true surgical challenge lies. Type 2 breaks right through both sphincters and into the ischioanal space. Type 3 loops dangerously up and over the puborectalis muscle before coming back down. And Type 4, that one completely bypasses the sphincter complex altogether, running essentially straight from the rectum, through the levator ani, and out to the skin.
Which brings us to Section 4, the surgical decision matrix.
So, with the anatomy classified and our map drawn, we finally arrive at these high-stakes surgical decisions. And I really cannot state this powerfully enough. The absolute first rule of fistula surgery is that you must never, ever perform a simple lay-open fistulotomy, meaning unroofing the tract, on a high, complex fistula. The crucial thing to remember here is this magical threshold of 30%. Dividing anything more than 30% of the external sphincter complex, or honestly touching any portion of the puborectalis muscle at all, basically guarantees severe, irreversible incontinence for your patient.
So, to solve this complex fistula puzzle without destroying the sphincter, we have to rely on advanced sphincter-sparing techniques. First up, we can place a loose, non-cutting seton. This just acts as a drain to eliminate sepsis, let the tracts mature, and prevent recurrent abscesses. The second option is the lift procedure. Here, the surgeon directly accesses the intersphincteric space and meticulously ties off the tract without cutting a single fiber of the external sphincter. And finally, we have the endorectal advancement flap, where a mucosal flap is actually pulled down from the rectum to securely patch up that internal opening.
Now, when we step back and compare international guidelines on these high-stakes decisions, we see some really solid standardized protocols. The ASCRS strictly demands these sphincter-preserving options for complex cases and strongly discourages the outdated practice of using cutting setons. Meanwhile, NICE and the ESCP mandate preoperative pelvic MRIs or endosonography. Why? To be absolutely certain no hidden occult tracts are missed before you even set foot in the OR.
All right, Section 5, Clinical Pearls and Wisdom.
Let's wrap up the clinical analysis portion of this explainer with some highly actionable bedside wisdom. Down in the emergency department, if you see a perineal abscess, you need to drain it immediately. Keep that incision as close to the anal verge as you possibly can. Do not wait around for fluctuants to develop, and whatever you do, don't rely solely on antibiotics. Delaying drainage literally just allows that trapped pus to destroy more tissue, which often transforms a simple abscess into a devastatingly complex high fistula. And up in the OR, thinking back to our opening case study with that 35-year-old guy, never, ever force the probe. If you feel resistance, stop. You are not in the natural tract. You're about to punch a hole right into healthy tissue, creating a false lumen and causing a massive supralevator disaster.
So, as we wrap up this explainer, the ultimate question every surgeon and clinician really has to face is this. Are you truly prepared to accurately map this disease, balancing the aggressive cure of the fistula against the devastating lifelong risk of iatrogenic incontinence? The anatomy here is incredibly unforgiving, but with the right map, it can be navigated. Thanks so much for exploring this with me today. Keep questioning, keep mapping, and I'll catch you in the next explainer.